And with that said, Mr. Gaines, the floor is yours.
Thank you very much, Tara. Welcome, everybody. Good to see you all. Hope you're getting through these current times and challenges well. We want to thank all the clinicians for what they're doing and the care teams. And hopefully these forums are helpful to you. All of our stuff is out on the web. It's not password protected behind a firewall. So let me jump right into it and introduce, first of all, Lisa Maurer, who's a practicing emergency physician, director of advocacy and payer relations for Consensio Health in Milwaukee, Wisconsin, a Democratic group, several 100,000 visits. Lisa does a lot of other things. She's the past president of Wisconsin chapter of ACEP, very active in ACEP, just finished a reimbursement fellowship, member of state ledge and reimbursement committee and EDPMA committees as well. And Dr. Jay Mullen, who's CEO of Blue Water Emergency Partners, a multi-state Democratic group in New England that staffs EDs from 10,000 visits to 36, and a total of about 125,000. You can see also very active in reimbursement. He's the chair-elect of the Democratic Group Practice Section and the past president of the main chapter. So really, Jay and Lisa are going to lead this. I'm going to facilitate the chat and the discussion, but we won't waste any time and turn it over to Jay. Thank you.
Great, thanks, Ed, and thanks everybody for joining in on this early summer day. Here are some of the things we're going to talk about during our time together. Lisa and I are going to spend about 20 minutes, 25 minutes talking about the financial adjustments that need to be made as we all discover what the new world of COVID is. About 20 minutes in, Ed is going to be watching the chats, and we would love people to share short vignettes, short stories about what kinds of adjustments they've done. Really want to learn from each other about how to accommodate the changes that none of us expected. In order to simplify the process of talking about this, we're going to tell the story as a case study of a fictional independent emergency medicine group. We're going to call them hero emergency physicians. The story's made up, but the facts are going to be likely very similar to the stories of hundreds of groups across the country. We're going to take a look at a couple of financial statements that are probably familiar to you, or at least your leadership, and I'll walk you through it. So just to give you a sense, Heroes sees 36,000 annual visits. They collect about $150 per patient in collections. They do get some support from the hospital. They've got 6 owner physicians, 3 physicians that are on the partnership track, some APCs. And on May 1st, as they were first started to come to grips with COVID, they had about 37 days cash on hand, or $565,000. Now, an income statement just quickly has the revenue at the top, and then at the bottom are the expenses, and then hopefully this is a positive number showing how much profit there is at the end of the year. So COVID hit us hard. We, like many, were really expecting to be overrun by patients. We didn't expect to be underrun by them. And in fact, what we saw was total volumes down across the country somewhere along these lines, 10% down in February, then really down in March, April, and May. June is looking like it's making a slow recovery. And for the forecast, we're hoping we get back to normal sometime in September. Of course, there are a lot of questions about whether that's actually going to happen or not. You can see here, this is what Heroes was expecting, 3,000 visits per month, and they had this deep V as the patients seemed to disappear. So in early May, the group leadership called a partnership meeting together to discuss the looming crisis. And one of the first things that their group did, which hopefully your groups have done, is to look at the typical monthly income statement. So you take the income statement that's 12 months long, and you chop it down into 12 pieces to figure out what each month looks like. And so at the end of each month, they were scheduled to have about a $35,000 profit. Now, as they went through the drops in volume in February, March, and April and started to meet in May, their group, like yours, may have had a few members that were like, what are you talking about? We got tons of money in the cash account. We haven't seen any drop in our checking accounts, even though you say that we're losing money. So how can that be? Well, in fact, when you look at the losses, right, they lost volume in February, March, April, May, and then hopefully they slowly come back to normal. And you can see the big drops in revenue. Now, as of May 1st, this group, like many, hadn't actually decreased staffing because once again, we were expecting to get overrun, not underrun. And so now the leadership, like many of you, have to convince the owners that there's a problem here. And they have basically about, several $100,000 worth of lost revenue that's going to be hitting them. So why are they feeling like it's not a big deal right now? Well, this is because of the timing of revenue streams. So the money that's earned in February, when you see a patient, doesn't actually, the chart doesn't get coded, doesn't get billed and sent to the payer and cash coming back into the account for about 60 days. So typically the patients that you see in March are the ones where the cash gets delivered to the cash account in May. So there's always a lag in changes in volume, whether it goes up or down. Expenses come right away, but the revenue comes later. And this becomes really the most important slide of all, probably, which is what, if you were to do this for yourself, you would probably see something similar. Back in the beautiful days of fall, we were seeing that volumes were consistent, we were making steady profit, and therefore our cash account was going up. Volume started to fall in February, but we didn't feel it, and then it was really in April and May when the cash burn really started. And you can see how precipitously it goes. And for this particular group, they were looking at bouncing their first check in July. And I don't know about you guys, but my APCs and physicians and administrative folks don't enjoy getting a bounce check in their payroll. So heroes, just like all of us, had to really figure out what to do to decrease their cash burn. So there were a number of levers or adjustments that heroes could make, just like we can make, to reduce our costs. And one of the keys is going to be to aim for flexibility, because we can predict pretty well what the volume is going to be tomorrow, but it's going to be really hard for any of us to predict what it's going to be a month from now, let alone 6 months from now. And so Lisa's going to bring us through some of the considerations that groups can make as they figure out how to respond. But first, I'm going to talk about one of the most important ones, which is adjusting staffing. So many of you may use a model like this, and I'll walk you through it. These are patients. These blue columns are patients arriving each hour. And then this orange line is the capacity of your providers to see patients. So overnight, this group only has one provider on. He can only see roughly 2.5 patients per hour. And then as they add on providers, their capacity goes up. And so you can see that their capacity, it matches their demand really pretty well. So wait times are low, patient satisfaction is high. When they have a much lower patient volume, they've got to shed some of their hours because it's all just unnecessary expense. Many groups have made the decision that the physicians in the group are able to withstand financial ups and downs much better than the APCs. And so many groups have actually reduced physician hours more than APC hours. That's a value decision that every group has to make. This particular group did that, and they went from 32 hours a day down to 24 hours a day. Pretty big drop in coverage, but it turned out only to be about 25% drop in total hours, because you reach a limit. You can't change the staffing overnight when you get down to single coverage. But even just that one move saved them about $70,000 per month, which really helps. So that actually moved the first bounce check, if you will, from July over to the end of August. But they were still really in the negative here, right? And so what can they do? And the good news is that if you look far enough in the future, once volumes return to us, we're all going to be getting net cash flow. So the cash account increases over time. So the next trick that Lisa's going to talk about are how we can move some of these expenses and either get rid of them or defer them to a future period when we can pay for them. Because right now, cash is likely to be very tight over the course of the next few months. Turn it over to you.
Thanks, Jay. Thanks. I do want to continue the conversation about how to decrease expenses and switch levers a little bit from decreasing staffing to maybe some of those other compensation costs that we have on the first and second line of that expense ledger that Jay showed, into the more commission-based or deferrable bonuses and potentially other characteristics that come in a comp package that people don't see as take-home pay that might be better tolerated. I won't go through all the examples listed on the bullet points on the left, but I wanted to just highlight that those are some good examples of that type of comp package makeup that people might tolerate being deferred or even suspended for a short period of time. And again, as Jay mentioned, that is kind of a value statement that the owners and the makeup of your group would have to decide for itself, but wanted to leave those as great examples. Secondly, I wanted to point out that box on the right that shows that as you're considering what you might be able to suspend or defer, you need to consider the different provider and administrator types and their tolerance for the different types of compensation being deferred or suspended. You might want to compare a seasoned administrator who's near retirement to potentially an early professional APC and their dependence on take-home pay versus the import that they place on benefits, for example. And that is a group level discussion, but I think to highlight those different categories of clinicians and administrators really might bring that flexibility that Jay mentioned into your plan right now and going forward. On the next slide, I wanted to point out that as we're being so flexible and thinking about variable staffing, as we encounter such shifts in our volume, coordination with your hospital partner is paramount. If you are able to trim down your staff, but they trim theirs further, that bare bones staff that you feel can be so efficient and carry the department might not be so efficient or be able to carry the volume that is there if they're not supported with the typical workflows. So those decade and career-long relationships that your leaders have with your hospital administrators, with the department manager and director are so important now more than ever to make sure that you guys are mirroring your staffing changes to make the staff that's there as effective as they can be. And maybe a little bit more novel than that concept would be to kind of put on your hospital administrator hat at this point. They're facing new challenges, they're facing changes in patient flow, but how they respond to them is much different than how an emergency department leader or physician would think. It really would behoove us to think about the staff that we are taking away from the emergency department and what problems can we solve for that hospital CEO. I know I've heard of examples where, for example, if a local hospital has a huge surge in their ICU, it might be a win-win situation to take some nurse practitioners or other provider types and use them as deputized ICU nurses, working in conjunction with typical ICU nurses. There also have been, propping up, obviously, telehealth programs both for discharge patients from the emergency department, but all over as the patients transition to accessing healthcare in that way. Who's providing medical direction for those telehealth programs? It might be not an emergency physician now, but as those maybe hospital employed or other specialists kind of go back to the new normal in their typical clinics or in their typical inpatient roles, there might be an opportunity, even temporarily, as the hospital gets their feet under them and figures out what works long-term, where you can be the solution to a problem. And temporary positions in medical direction would fit really nicely with our problems right now as well. The last thing I wanted to point out in terms of different arenas for your staff to work in, you could certainly be the solution in an external staffing venue that might be in a tent that's external to the ED, but it might also be who needs to swab all the patients that need their pre-procedural or pre-operative COVID testing. Someone's got to do that, and right now they might have someone to do it, but as hospital volumes increase in your area, they might be scraping to figure out who's going to run those positions. Lastly, right now in many hospital systems, there's a transition to care emphasis, and it's in the bottom bullet point on this slide, but it also is a great segue into the next slide where they are filling those positions now. They are perhaps ramping up transitions of care programs where the patients are discharged from the emergency department with respiratory symptoms, and they have people in place that are taking care of them. Those people are going to get sucked back into their typical roles, and we'll be there to save the day and help fill in those staffing roles. This slide is to point out that it's a real skill set that emergency physicians and other providers have right now. That as of March, we were like everybody else. You know, you had that pit in your stomach heading to the department because you knew you were going to be exposed to coronavirus each and every shift, perhaps. And I don't know if I just speak for myself and how we do in Milwaukee, but these days we're kind of like Brad Pitt style. We're like, yeah, whatever, bring it on. It's old hat to us now, right? It's not a little of little consequence, but we're well prepared. It's a routine for us, and we have to optimize that skill set in different venues too, outside the hospital. We've heard of emergency physician groups who are even offering to other employers. You need all of your employees tested so that we can give you our company's stamp of approval that as of June 24th, all of your employees are COVID-free, stamp of approval. We can bust in and do that in 2 hours, no problem. We'll come in with our hazmat suits. It doesn't faze us at all. Not many provider types can come in with that kind of confidence and comfort doing that type of clinical work. There are also maybe new opportunities to partner with the state or with other kind of public agencies that are propping up alternate care facilities or testing. You might theorize that the National Guard can't be deployed forever with public testing facilities if that's happening in your area. There are emergency medicine groups that are contracted to staff these facilities that provide that kind of surge capacity if hospitals do get overwhelmed at any point in time, and that is often valued as a public service. And then lastly, as we talk about that transition of care, I wanted to just point out some of the regulatory flexibilities that we've been afforded and to take advantage of those as we might kind of harken back to the alternative payment models that CMMI has been thinking about for emergency physicians as crafted by ASAP. There really is an emphasis on touching patients at every step of the way to utilize our skill set for that care navigation and triage that we're so expert at. There was recently a new rule that they're placing a value on telephone encounters to value them at the same thing that you would, the same value as an outpatient clinic visit. What about all those patients that call the emergency department asking for medical advice? And usually the HUC tells them kind of a parroted, I'm sorry, we can't give medical advice over the phone. Well, what if we could? It's a low volume of patients, but if you're staffing for some other telehealth ventures or virtual care ventures, you might as well glom that kind of patient volume on as well. There's obviously the opportunity for patient-initiated post-ED follow-up or even pre-ED follow encounters. Payers and hospitals might value a safe discharge with that provider-initiated follow-up. And then we might be able to, as I said, utilize our skill set in the comfort with encountering patients with respiratory symptoms, even in that scheduled follow-up from ED or otherwise. So at this point, we were hoping to just take a pause and listen to some vignettes that were contributed by the folks on this call about how are you expanding your groups outside the four walls of the ED? How are you kind of taking advantage of the new regulatory opportunities? I've heard a lot of stories and we would be happy to kind of take your feedback. How are you cutting down on your expenses in interesting ways? What has been best tolerated in your group? I know, Ed, is there anything that you had received? I don't see much in the chat box right now that we could cover, but I have other examples that we could touch on quickly. Or
yeah, just one thing you touched on, Lisa, on the testing station. Article, I believe it was in Becker's in the last week, was highlighting that some of the payers, no, actually it was NPR, that some of the payers are rejecting claims for testing and treatment unless there's an order from the patient's primary care or the emergency physician for the test and the treatment. And you know, it's certainly out in the public realm, at least, that they think that testing and treatment is no cost sharing to them. Are you hearing that? Are you seeing that? Are you or Jay experiencing any of that? I'm just curious if that's impacting you at all.
You know, I don't think it's been long enough that we're hearing the feedback from the patients. I do agree with you that they certainly come in with the understanding that COVID concerns as they seek care in the healthcare arena, that will be 100% covered by their insurance company. That's been recognized at every level that, you know, we want to take care of you. But we talked about how oftentimes we encounter a patient where sure we have concerns for coronavirus in the emergency department, but maybe back in late March, we didn't even have the tests available. So certainly there was no order for a test or a test completed. Or
right.
Perhaps they were already diagnosed but had an exacerbation and had a higher level of care need. That encounter in the emergency department might not be covered under those same policies by insurance companies, even though they were most critical at that time.
Yeah, and what go ahead, John.
Lisa and Jay, one of the things that I heard from the president of a group was in the telemedicine environment, they had actually approached the hospital C-suite, and it was really kind of a twofold proposition. One, they were thinking that telemedicine could help them bring some of the volume back to the emergency department, but they also thought it would just help the hospital. And the challenge they ran into, they got pushback from the C-suite saying that they thought it would infringe on the primary care network. So they basically had to just back off.
Yeah, we've encountered that at a number of our locations where it seemed to make so much sense from the emergency medicine perspective because one, we could use it like virtual PPE. We didn't have to use any PPE over Zoom. And then two, we could actually take advantage of some of our providers who maybe were too high risk to actually work in the emergency department. And then oftentimes we had excess capacity in the ED. So we started talking to some of our client hospitals about expanding into the telemedicine world. And we met with acceptance by the C-suite for the most part, but then the primary care physicians oftentimes felt like they were going to have to compete for those visits.
Right.
The other part I would add is, at least what I've seen or heard from other folks, is the primary care world sometimes struggles with the show rate or the stick rate for our post-ED or even post-inpatient discharge patients that they're trying to get into the clinics. It might be valued by the hospital system or even the medical group that contains primary care physicians to have that high-touch experience after discharge that could include a telehealth encounter. The problem is it certainly would need to be valued by the medical group or the hospital, seeing as that's not necessarily a separately billable service if it's truly just like a touch base after an ED visit that includes care navigation assistance. But you could get it from that angle.
Great. Well, let's finish up with our section. So our heroes, hero emergency physicians, made the changes that Lisa and I outlined with their staffing, deferred a lot of their productivity payments and bonuses. They were also able to defer some of their other costs, and they were able to actually get themselves to a point where they didn't run to zero in their cash account. And now with things like the PPP loan or other grants that they may have received, they're probably in an okay position. You may have noticed I said probably okay because we don't really know. This is assuming that volume comes back, and it may not come back. And in fact, what we may find is that we see this variable volume for a while. So two last things we want to talk about is one, can you get help from the hospital? If you are a 50,000, 60,000, 70,000 visit emergency department, it's probably pretty unlikely that the hospital is going to step in and try to make you whole. On the other hand, if you were already getting support from the hospital because volumes are so low that it can't even support single coverage with an emergency physician, then many groups that I've heard of are having luck having conversations with the hospital, especially if the hospital was not furloughing any of their employed staff. Now, this makes us all nervous in the independent and democratic group world because we always feel like if we ask for more money, that puts a laser target on our back that the large contract management groups may take advantage of. But I think it's worthwhile having the conversation. The other thing that can happen is if you've built into your contracts a circuit breaker or a relook if economic conditions change, that can be really helpful. If that's not in your contracts, you might think about it. So in some of our contracts, we make sure that we stay within a fair market value range of compensation, and something like this may change that. And this gives us the opportunity to engage with our hospital partners. I'll give you an example of a group that I am aware of that they operate an emergency department in a resort area. And typically volumes in the summer months go up by about 50%. There was a lot of question a couple months ago, is that going to happen? Are people going to come in? Are they going to be able to rent? Are they able to feel safe enough to come to this resort area? And so the group talked with the hospital C-suite and said, what would you like us to do? We can't take the risk of putting double coverage in the emergency department, not being sure if the volume's there or not. And the hospital was very clear that they felt that that was such an important thing that they offered a revenue guarantee to make sure that there was double coverage because they recognized that pleasing the summer volume was really important. And they didn't have anywhere else to turn to be the pressure relief valve other than the emergency department if any other part of their system failed. So as Lisa said, you know, we are the Brad Pitts of Fight Club, not just in our approach to infectious agents that are novel, but also in our willingness to kind of MacGyver a situation. So oftentimes the hospitals are really willing to recognize that. The other two levers that we have that are a little bit more difficult are renegotiating contracts. So typically owners in our groups have a variable contract. So, you know, the tide floats all boats. So when the group does well, the partners do well. When the group does badly, the partners do badly. But typically our non-owner physicians and APCs and administrative staff have a more fixed rate contract. And so many groups are having difficult conversations with their non-physician owners, their APCs and their administrative folks to see if they can get them either onto a more variable format or to at least decrease the number of hours that they're being guaranteed. And then there's always the surge. Every conversation I've had with my group and my partners and my frontline staff, we've vacillated between the reality, which is we're sitting there ready, to the old reality when we just had way more work than we could possibly handle. And there's always the fear that even though we're experiencing this at noon, that at 4 o'clock it's going to look like this. And so with our groups, what we've done is rather than cancel shifts, we've made them call shifts. Other groups have taken their shifts and just shortened them so that on any given day they can lengthen them. Those are all really useful. And what we've found is probably what all of you have found is engaging the frontline staff in these conversations. I've been amazed at how willing people are to recognize that this is an uncharted territory. None of us could have predicted this. And people are really willing to grab a paddle, and especially if their voice is heard. The reality, though, is that we may end up having to do the right sizing move of force reduction. And as we all think about this, we're going to have to decide between furloughs. Furloughs are, of course, where you maintain somebody's benefits, but you stop paying them. Technically, that person can't do anything for the group, can't check email, can't answer phone calls, can't really talk to you. Not that anyone's necessarily looking over our shoulder in this pandemic, but that's typically what a furlough is. Whereas a layoff is where you actually are parting ways. And so none of us want to approach any of those, but obviously a furlough is easier to reverse than a layoff. And then compensation reduction or reduction in benefits is something that we'll have to consider. As we move into this new world, the post-introduction of COVID world, we're gonna have to decide, is compensation gonna stay the same for physicians? You know, 6 months ago, we were undersupplied with emergency physicians. Is that the case anymore? We just don't know. We're gonna have to watch it really closely. And then next steps in this regard are to remember that advocacy is so important. So as groups are looking at things that they can reduce in costs, I really recommend that you be a voice to keep contributing to things like NEMPAC, ACEP, AAEM, and to make sure that you continue with your partners like Zotec to make sure that you're getting good advice, you're getting people like Ed working every day for us to make sure that they're keeping an eye on the regulatory and legislative changes, because those can have huge impacts. Next, Lisa and I are both founding members, along with several others, of the Emergency Medicine Business Coalition, which is a group of Democratic groups from across the country that are getting together to try to figure out how to learn from each other, how to become better at the jobs that we do, how to answer questions about which electronic scheduling platform is better, what do you guys pay as a percentage for administrative costs, and also to take advantage of our group purchasing power. And it looks like we're going to realize some really huge savings in some of our benefit packages, which is awesome. IEPC is a similar group that's been doing that out of California. I heard from Ed today that there's a group in North Carolina doing that. And then a plug for the Democratic Group Practice section at ACEP, because this at ACEP is a great way for us to get a voice that really has some leverage behind it. When we talk to the board of directors and to the candidates for the presidency, they really care what the sections are saying. And so I'd recommend all of you joining the Democratic Group Practice section. I think, Ed, we're going to be holding off till questions till the end. And so just a reminder before we move on to the next section that all these materials, including slide decks, will be on the zotecpac.com website. And Ed can certainly navigate you there if you forget. And next, I'd like to introduce Dave Hall and John Holstein. They're going to be addressing the topic of alternative payment models. So now now that COVID is a part of our lives, is anyone in emergency medicine even considering an APM? And in fact, I think Dr. Hall and John are going to convince us, yes, they are.
Dave?
Take it away, John.
Okay. Dr. Hall, are you with us?
I was muted. Sorry, there we go. I'm
There
on.
you go.
I'm on now.
Okay. Everyone, Dave Hall is the president and CEO of Independent Emergency Physicians in Farmington Hills outside of Detroit. Welcome, Dr. Hall. But we're not, as you know, we don't have slides. This is purely discussion the rest of the session today. So why don't we start off a little bit ahead of the APM discussion. Dave, can you give us your thoughts on, is this a good, better, or not an interesting time at all for independent groups to start talking about engaging or continuing engagement in ACO arrangements?
Right. Thanks, John. Good afternoon, everybody. Well, I think the obvious answer is in the setting of what COVID has done to our specialty, the world, flipped everything upside down and made us really front and center of a lot of changes. Now is most certainly the time to at very least look at all of this. Our group out of Michigan, we've been pretty innovative since the beginning of our inception with the group, which most Democratic groups have, and you have to kind of navigate through and decide if you're going to get involved with other parts of emergency medicine, if you're going to be just a staffing company, if you're going to start going and reaching beyond the CDU, which many of the groups in emergency medicine have done. And part of that is probably considering something such as an APM model. I think we are at the very beginning and in its infancy of discussing it. But, and this discussion kind of went on before coronavirus hit. And then once this occurred, I don't know that there's been a ton of traction as of late, but I think now is the time that we as emergency medicine practitioners, including the larger groups, need to start considering how can we find value and find opportunity in the setting of lots of change. We have to, of course, stay relevant as a specialty, and that's never going to go away. But we don't want to lose control of our own business models, of our own hospitals. Emergency medicine has really carried the way for a lot of leadership in the hospital system because we have a unique understanding of what goes on. ACOs, CINs have probably reached out to most private groups and tried to get them to join them from a hospital perspective, whether it was heavily internal medicine or heavily specialist driven. It's always a little bit different, and they always reach out to emergency medicine and see if we can be a part of it. At least we've experienced that on our end. But what that's done is usually we try to just play nice with all of our colleagues and get engaged. But now that there's some more opportunity that exists, we really need to consider as a specialty, how do we stay relevant and how do we look and consider an APM model that maybe we didn't consider it as before in the past. And our group has kind of been more open to it. It's a bit of a challenge now, but I think now is more important than ever to try to get after it and see if there's something to be gained in there.
Dave, on the APM models itself, do you feel that independent groups have the infrastructure? I mean, given that the data demands and reporting demands will be different, for lack of a better word, different and more enhanced, are independent groups prepared, particularly in the context if you take the ACEP Awesome model that clearly extends the care continuum out into the community, are independent groups prepared for this kind of model?
Well, certainly there are more sophisticated independent groups than others. Some are they've been around in a single hospital system for a long time. Maybe it's 8 to 10 doctors running a single emergency department. They just want to be able to be in control of their own department. They're very engaged locally. They're very engaged with their single hospital, and maybe they don't have any other competition in the area. And then there's a bigger independent groups that start to become more and more sophisticated as time goes on, trying to remain relevant. Us in the Metro Detroit area, we have multiple hospital systems we compete with. We have a very dense population. And with that brings multiple different specialties and versions of emergency medicine groups, such as, IEP, where I'm at, which is a multi-specialty group now. We've gotten into hospitalist medicine and everything else. So for a group such as us, trying to stay not only relevant, but ahead of the curve with everything, we're ready to kind of lead the charge and sit there and be part of some of that. Other groups, maybe, you know, they're just trying to drag along and make it last another 5-10 years. But I think any size group could probably start to look at how they can make an impact, how they can make a difference, and how they can actually carry on creating some work for themselves in the APM world. So any size group should be able to do it. What it's really going to take is some ingenuity on the docs in the practice to say, are we just staffing these emergency departments, or are we trying to drive our specialty to something bigger and better? And if that's the mindset they have, then everybody can be a part of this, and should be.
I think, I know Lisa touched on it, Jay's touched on it in the context of telemedicine, but I've heard other groups, other physicians talk about other revenue opportunities within the hospital. So it's not just the extension of the care continuum, but I know I've heard one physician talk about, you know, kind of unfound or previously unfound revenue opportunities just within the hospital. What are your thoughts on that? And I have some other questions coming up, but what are your thoughts on that, Dave?
I think we all have to try and, depending on the competitive atmosphere that you're engaged with, we have traditionally as a specialty gone into other revenue stream opportunities. CDU was a sort of an easy one for all of us, right? We jumped into CDU when there was a need in the hospitals. I don't know which state it started in. Like, observation medicine became a big piece of emergency medicine, and we knew that we were uniquely qualified to handle all these unscheduled visits. And, you know, I think Emergency Medicine Practice Council did a really good job of making sure that they were looking to say, hey, we are the master of the unscheduled visits, and that's everything from the short stay to maybe even the urgent care setting to something unique such as telemedicine, which many have gotten into. I think independently, the group mentality has been to look into wherever you can provide value to remain relevant, so we can do what we really love to do, which is emergency medicine. And then some of the docs that specifically just work on the floor say, you know what, we just want to practice the emergency medicine that we have. We want to take care of sick people only. We don't want to take care of the coughs and colds. We don't want to take care of the people who want to schedule, that want to come in because it's convenient for them. And I think the sophisticated groups or the emergency medicine as a whole kind of says, you know, we probably need to start to get into some of these niche type opportunities. We struggle with the idea that someone might schedule an emergency medicine visit as a whole. I think many of us internally, our internal system says scheduling an ER visit isn't that counterintuitive to what, you know, our whole purpose is. On the other hand, instead of fighting some of these things, we should probably try to find a way to embrace them, make them an alternative model for us, but also make it so that it still works for emergency medicine, so it's done the right way as opposed to completely commercial to make a buck or two.
With Lisa and Jay and Ed leaving off, we're talking about the already existent groups regionally in the country. Is this something that the independent groups really need to kind of charge in with the white hat, so to speak, and really trigger a response from the rank and file within the specialty? Or maybe, if not just a question, is it something, but how would it be done?
How would it be done to get, well, you know, first of all, the independent groups to survive longer than a few years have to provide something better than just staffing the emergency department, which is what our bigger counterparts are doing, right? They're so large, all they're able to do is staff emergency departments, and they're not aligned from the corporate end all the way down to the detailed democratic end. So what happens is if we start working together instead of on islands, which I think is what, you know, Lisa and Jay had spoken about, with kind of combining a bunch of different independent groups together and creating synergies together, then we start having discussions like we are today. We start driving the specialty forward and starting to be no longer just people who drive our own communities that we're in, but also drive the discussion nationally. Of course, the bigger contracted groups right now are getting painted in a really tough light in the paper and in the media right now, and some of it might be a little bit unfair, but some of it has very good merit. And what happens is the communities want to have their doctors in their communities that they live taking care of them. They want to know that they're invested in the communities, and you start with that. You can invest in your communities, talk about how we use our synergies amongst all of our democratic groups or all the smaller groups that are willing to work together. These groups can really drive the needle because now you have a huge base of physicians and practitioners who are really looking forward to make the next step and work together as opposed to just try to hold on to what they have. So we have to find a way together to kind of create our synergy and all drive that process.
On the patient side, I mean, the specialty's always been respected as strong advocates for patient access, strong advocates for your patients, period. As we talk about an APM model and extending the kind of traditional core services of emergency physicians even out into the community, what are the patient engagement tools that you feel? What is the infrastructure that you feel? What do you need from the business side of emergency medicine to execute these kinds of models?
You know, what we have to do is really, a lot of times we're all scientists, right? So metric-driven details and understanding of our own business is key. To kind of use numbers to drive our hospitals to knowing where we're headed and what we do differently than everybody else, what we do better than everybody else. When we have metrics, we can actually compare groups together and say, hey, our group is doing X, Y, and Z, and this is how we accomplished it. Now with those numbers, the other groups can kind of tag along and say, well, how did you do that? And therefore, it's no longer anecdotal because we're engaged on it, but now it's something that we can just follow metric-driven or follow it with data. So I think, John, your question is kind of what's going to be the key to getting this to move forward and be successful with that. It's kind of a combination of all of those things, right? We all have to be open together with the things that we don't know. And we have to be open to what other groups are doing. We have to be open to something that maybe is outside our comfort zone. And to do that, we probably need to get aspect of our business models, understand where the finances are coming from, be engaged with our negotiated contracts with Blue Cross Blue Shield, VCN, and whomever else. Doing that helps out by kind of having an understanding of what everybody's doing and then having a willingness to change outside the norm as opposed to just say, no, this is the way it's been done for the last 25 years in emergency medicine, so let's continue to do it.
Dave, something you and I spoke about ahead of today, I think is important in the context of our current discussion, and that is it time for the specialty to branch out and engage employers directly, not just insurance companies? I think it's pertinent to an APM discussion.
Sure, I think that's probably where you're headed, because I think when you try to tackle an APM, it's such a big topic. You want to have it all boxed up and ready to go right away, and I think that's where it stalls. So you start with the philosophy and the theory. I'm not sure if anybody has, an occupational health type contract set up with what you have out there, but essentially you engage with usually a health system or somebody, and you manage their health accounts for a flat rate. Well, there's nothing that says that our emergency departments can't reach out to, say, Coca-Cola if they're big in your area, or Consumers Energy, or Kellogg's, or whomever is there, GM, Ford. In my area in Michigan, it's a lot of the cars and the auto industry. But what says we can't look out to them and sort of bundle package their payments, giving them a sort of a discount? They want to come to our hospital systems because we take their insurance and they see us. Now you have to get inventive, because now you need the hospitals from their standpoint to handle it too, because part of the big cost to patients is not necessarily the professional fee, which we all have, but also the fees of being in the emergency department. So if there's a way to engage with those big groups, save them money on the insurance side of things, make it a flat rate that we know is dependable, you can look at that way. Well, we own and operate some urgent cares, and that's the way our setting is for them. It's a little easier, but there's nothing that says you can't develop some sort of model through the emergency departments that run that same way. It's at a risk though, because you get into that way, you have to make sure that you're following the proper rules of engagement there. You can't charge more or less than market rate. You got to be careful with how that works out, but that sort of ties into how we get an APM model where there's some cost saving with economies of scale that go out there. I don't know. I wonder, I'd be interested to hear if any other groups have done that on an emergency medicine level.
Dave, I think that's a great segue. I think we're edging towards having hopefully some time here for open discussion and open questions. I think that's a great segue to just open it up now to the whole group.
Yeah, I was just asking on the chat. Great, thank you, Dr. Hall and John, for that. If groups have gone out on telehealth or employee testing, it sounded like, Lisa, you guys are mulling it over or considering it. I know friends of mine who have small businesses. They're like, okay, who do I talk to about getting testing arranged for my employees? Because we're going to start slowly letting people back in, and they go to the hospital, and the hospital says, we'll charge you a $75 per person administrative fee plus the testing cost will be billed to the insurance. It won't come out of the patient's pocket. But it seems like the hospitals are really looking at this as a great opportunity for them.
I wanted to share that our experiences, we have these ideas, right, to meet people where they're at via telehealth or on the job site, both in terms of occupational health, preventing ED visits, following up inpatient stays. And the insurance companies are interested. They just are slower moving machines than employers who are contributing to their employees' health benefits and would love to see that price tag go down and see their risk go down. And so they're just a little bit more agile and interested in getting something started in a few months more than getting something started 2 years from now. And so I think your comments, Dave, are right on point that might be, if you get the tenants propped up working with an employer, then you have a package that's more polished to then present to a bigger machine like a payer. So
Jay, I see your question, your comment on the chat. Tell us a little bit more about your discussions. What are the key pressure points for the grocery store chain?
Yeah, so the grocery store chain is really interested in getting some kind of a seal to show that they're testing their employees periodically to really help kind of reassure the customers that they have. One of the challenges they have is that their frontline staff aren't insured and sometimes make too much to be on Medicaid. So they're really concerned about the costs that are associated with that. So working through making sure that they get coverage is really important to them. We've also talked with them about the possibility of having a coupon rate where the employer could actually pay for it. And because we guarantee that it's offered to a certain number of people, we can actually offer a much lower rate than the $75 per visit, as you discussed.
So is this maybe an opportunity for a subscription model, maybe? I mean, kind of a quote unquote Netflix type model where they would subscribe to you and you would do a certain a certain basket of services for a period of time.
Yeah. Yep. One of the challenges we have with testing employees is putting our name on it, because we all know as physicians that testing somebody today doesn't mean that they don't, catch the disease tomorrow. So we want to make sure that we're not sending the wrong message from a public health perspective, but figuring out how to also meet the need that employers have, which are real. The other piece that we found is that the employers oftentimes don't have somebody to turn to ask questions. And so by engaging with them, we also are able to answer some of their public health questions.
Dave, you mentioned patient engagement tools and data and metrics. What are you guys looking for, particularly from your RCM? What are you looking for in terms of platform capabilities, data? Are you looking for the ability, for example, if you're going to do testing or you're going to do outpatient services, the ability for patients to schedule, say, with their mobile device, those types of things? Is that what you're looking for?
We have one thing that's unique to, I'm going to answer that, Ed, and also kind of piggyback it on what Jay was saying. When employers reach out, they do not have typically somewhere to go to, and they certainly aren't accustomed to talking to physicians directly about their care, not in the emergency room setting. So you provide sort of a concierge service to them by saying, hey, this is the president of our company or the executive that handles this branch, ambulatory care or whatever it is. And you bring that face right to them, And now all of a sudden they're bringing you 300, 400 employees. You're bringing them a face and you're saying, hey, we're local. We're here to make a difference. We want to work with you, because they don't get that experience with even the hospitals sometimes, just because hospitals are big machines to do it. So they sort of backdoor themselves in. If you can go to your hospital employer, to your hospital system that you're contracted with, and you can say, hey, I have a contract over here at the grocery store, and I have no idea how many people it is, it's irrelevant, but and just say, we're going to bring them all to your system. Especially if you're in an area that has multiple systems, they're going to say, well, this group is not only inventive, they're bringing themselves business, they're bringing us business. What can they do in other markets that they're in? So the question is, on top of that, to your point, Ed, when you do that, you don't want to just bring them a way to talk to you, but take it another level. Say, we're going to actually go through some metrics with you. We'll keep on the back end and find out how many of your employees we've seen, what the cost has been, and then you can reverse work backwards and tell them what their cost savings is. You basically tell them that, and then you're sharing it with them. To do that, of course, you have to know your own business and know your own own model there. We have a contract with Michigan Department of Corrections, so instead of them having two sheriffs get in the car and bring a prisoner to the emergency department because what could be a simple cellulitis, now they do a telemedicine visit with us on a flat rate. We compared that to what it costs for, say, a level 3 99283 or something like that, which is a lot of them what they are, and then do the delta on the cost savings for them, and not having to pull the prisoner out of jail, spend on the transportation, spend on 2 officers being with them for 2 or 3 hours, plus the security, et cetera, et cetera. And then you bring the metrics back to them and say, hey, this is how many calls you went from, 30 visits a month to now 7 visits a month, and we did the X amount of calls. And so everybody sort of loves data, depends on who you're giving it to, but if you can capture all those metrics for them and say, and we finish these phone calls in a period of 10 to 20 minutes, as opposed to a length of stay that averages around 4 to 5 hours for them, or whatever number it is, you kind of share that data with the employer, the consumer group. Next thing you know, they've actually created a relationship with you in the community that they like, plus you've created more business for yourself. You look good in the hospital's eyes, and you're able to actually provide an improvement in service, which is what it's supposed to be about. It's all about the patient.
That's a great example. Jay, Lisa, comments on that, those types of settings. I mean, you could say prisons. There's a whole bunch of potential settings there that might be open markets for you.
Yeah, I would say the other setting that is ripe for something like that is assisted living. Because we worked with some nursing homes for a while to try to figure out how to reduce their ED visits and therefore reduce their admissions, because we know that as soon as a nursing home patient comes to the ED, there's so little information that we have that oftentimes they end up getting admitted. And what we've heard from the nursing home administrators is that they were more concerned about their sister organizations, the assisted living, because they don't even have a nurse that can actually check in on a patient. And so many times, our telemedicine visit could cost less than just the ambulance ride. And so we're having those conversations. COVID has kind of interrupted that, but I think that that's a great area for people to look at.
And I would echo that in saying that it's the group homes, it's the places where people have to congregate out of necessity, but they don't have the built-in nursing structure or providers on scene. But they feel that it's such a great risk to send their residents into the healthcare arena right now. This might be temporary before that comfort level returns. Who knows how long it'll last, but that on-site or even virtual visit is going to be so valuable to managers of these facilities right now.
Jay, you were talking about the importance of advocacy and how critical that is. And a lot of these telehealth changes we know are tied to the public health emergency, which expires in about a month. Assuming that gets extended and some of these telehealth changes get made permanently, do you see major changes that have to be made yet in telehealth, either the reimbursement or the approach that at least CMS has made in terms of the changes implemented? Are there, just from our own advocacy agenda purposes, are there missing things that we could have, that we should have today that we don't have?
I think Whether or not the payers pay for the telemedicine is, of course, important. The group that I think is almost agnostic to what the payers do are some of the groups that John and Lisa touched on. Because when you think about that prison system, they don't care at all about the ED cost itself. Well, they care some, but it's probably just a fraction of the overall cost of the 2 sheriff's deputies transporting the patient. And that's so true for group homes or nursing homes as well, that they oftentimes lose revenue. And then even with the Medicare population, oftentimes a telehealth visit can be less expensive for the elderly patient than their copay for the ED visit. And so we've heard of groups that are doing that, where they're actually just pricing themselves so that they're still less expensive than just the copay rate for the ambulance ride.
One area that I would propose as a suggested opportunity for the specialty is, given the impending changes right now, is the university settings for testing or screening of their students.
Absolutely, especially, I don't know about other parts of the country, but in New England, a lot of the universities are having only their freshmen on campus. And so that raises the question, are they going to have the same infirmary hours as they did before? And so I think that's a great point, John, of contacting those groups and seeing if you can help them.
Well, we're almost up to the hour, guys. Other comments or questions, or any last chat questions, please? John, did you have a comment?
I was just going to say, along the lines of that last point there, I'm kind of thinking out loud here, but in terms of approaching universities, that could actually even kind of be scaled in terms of the bigger universities, particularly that have significant international populations. It's going to become a really big issue.
So Lisa, Jay, Mark, any final, David, any final questions, comments?
My comment to this would be, I think as emergency medicine physicians, we do want to practice emergency medicine, and if the leadership wants to branch out and be more inventive, maybe our partners don't. My group's pretty good with that. They like the challenge of getting into other things, but it's still difficult because now you're getting into telemedicine and urgent cares and things of this nature, and we say to ourselves, but it's still better that I touch the patient, put my hands on the patient, an ER trained physician or even an ER trained PA or NP that has done a great job with their care is still much better care. But what we're talking about is not worried about losing that patient population. They're not going anywhere. The heart attacks and strokes, at least once COVID's gone, they'll come back in. They're going to come in. But there is about 15 to 25%, depending on what setting you're in, that those patients are probably not necessary for the emergency department. And my suggestion would be for us not to fight that so much as provide alternative ways to capture those folks, capture those people either in our urgent cares or in our telemedicine visits, or if you have an outpatient setting that's a lighter acuity. So I would say eventually it's going to push that way anyway. So instead of fighting it or saying we don't want these patients, get them to where they need to be, provide that there. And our practice model is set to be a uniquely qualified for it. These nursing homes, they have primary care folks that cover the phone calls, but we see what they send in the middle of the night. So-and-so's toe is red. Well, I can't look at it. I'm uncomfortable. Send them in. Maybe it's gangrene and it needs to be handled at 2 a.m. So, but our docs and our PAs are able to handle that. So my last minute thoughts would be, we have to be inventive as a specialty. Even if our groups are doing it, we want other groups to do it because we do have a pretty good skill set to manage it. And I would say, don't fight things that you're not comfortable with, like unscheduled visits or telemedicine or even urgent cares. Instead, embrace it and be the change and make them work to our favor.
Embrace the change. I like that. Jay, could you go back to that previous slide just so everybody knows where the materials are, and the recording for this along with the slides will be there at zotecpac.com COVID-19. That's where all of our COVID materials are located. Lisa, you had a comment.
I wanted to echo what Dave was saying and to, also highlight that the more that different groups across the country are able to utilize these temporarily allowable and valued codes, the more we're able to branch into these new venues that temporarily are available to us, the more it'll be an onus on the regulatory level at the federal level to say these really should be permanent, because look what they did with it. So platforms like this webinar are perfect for us to share notes, share ideas, and light this up across the country so that it does kind of link to that advocacy level of this is what's best for the patients. This is how we were able to put it to good use so that we should be able to keep these as a permanent fixture of our specialty.
Jay?
Yep, very well said. Thanks so much, Ed, John, Dave, Lisa, and Tara for putting this together. I really enjoyed taking part and would love to hear more from everyone.
Great. Thanks, everybody, for
everyone.
your contributions to my colleague, John and Tara, Lisa, Dave, and Jay, of course, for their just great generosity in helping us with this. And we'll see you, we hope, very soon. Take care, everybody.
Thank you, everyone.
Bye all. Thank you.
Bye-bye.
Bye-bye.